Continuing our discussion of glomerulonephritis, we are still within the realm of nephritic disorders. And with nephritic disorders, at this point, you should be pretty good with what the overall signs of the patients are, including your hypertension, hematuria. With hematuria, it's RBC casts, dysmorphic RBCs, oliguria, and as far as protein loss is concerned, less than 3.5 grams of protein per day may result in periorbital puffiness. Continue discussion of nephritic with post-streptococcal glomerulonephritis. Now, earlier, when our discussion began with the overview, I gave you the most common glomerulonephritis or nephritic disorder overall, and that was your IgA nephropathy. Now, we take a look at PSGN. This is the most common type of post-infectious glomerulonephritis. Is that clear? In a little bit, I'll give you some non-infectious glomerulonephritis. Now, with post-infectious, this would be most commonly following weeks after exposure to an organism, bacteria known as group A streptococci, and here, of course, we're referring to Streptococci pyogenes. Now, before I give you pharyngitis, which many of you, most of you are quite familiar with, I have to point out to you skin, skin, skin. And by skin, maybe perhaps you have a skin infection by the same organism, so that's not going to differ. It'll be still group A streptococci. However, with the skin manifestation, maybe in the form of, as an example, scarlet fever, impetigo. Then weeks later, we have issues with the kidney in which there's hematuria. Your most likely situation, diagnosis, PSGN, post-streptococcal glomerulonephritis. Now, what you will have to memorize is the fact that it's subepithelial immune complex deposition. Make your life a little bit easier. P as in post, P as in sub-epi. What does that mean to you? Are you on the side of the urine or are you on the side of the blood? You're on the side of the urine. Is that clear? Where? Between the podocyte and the glomerulobasal membrane. On immunofluorescence, what are you going to call this? Granular upon immunofluorescence. What about this immune complex pathway? It is then going to activate complement pathway, so therefore look for a patient that has hypocomplementemia. Now, on light microscopy, you're going to find diffuse proliferation of that glomerulus. So in your mind, you should be thinking as to what a light microscopy normal looks like of a glomerulus. And then here, with PSGN, we have diffuse proliferation with neutrophilic infiltration. Remember, with nephritic, quite a bit with neutrophilic and oftentimes with immune complex involvement. With post-streptococcal glomerulonephritis, we have 1 to 3 weeks after infection with the group A streptococcal. This will be something like your Streptococci pyogenes. We talked about this. Now, what becomes important is the next statement. Every one of these statements here are extremely, extremely common and quite important for you to know clinically. The nephritogenic strain might then give rise to your PSGN, post-streptococcal glomerulonephritis, but however, it will never produce acute rheumatic fever. Rheumatic fever. What is this that I'm doing? I thought Dr. Raj dances. No, that's called Sydenham chorea. Is that part of rheumatic fever? That it is. Number 2, there's arthritis. Maybe the elbow, maybe move down to the knee. It's called migratory polyarthritis. And so that's also part of rheumatic fever. Number 3, there might be issues with the heart, endocarditis, myocarditis, pericarditis, collectively, pancarditis. Is that part of rheumatic fever? That it is. There's skin involvement that you might find. It's known as erythema marginatum, also part of rheumatic fever. Now, what I've given you there is the major Jones criteria for rheumatic fever. Now, with post-streptococcal here with the nephritogenic strain, nephritogenic will never cause heartgenic or cardiogenic. It will then cause strictly your PSGN. Now, the rest of this is following suit with nephritic disorder, which means that you might lose protein, and you will, up until 3.5 grams of protein, and here the edema, periorbital puffiness is what we talked about, sodium retention. It can be occasionally more extensive, and usually not due to hypoalbuminemia. It's the fact that you're retaining your sodium. The hypertension here is transient, but at times could be severe. And that's something that you want to keep in mind, especially in a child, In a child that was inadequately treated for a sore throat or pharyngitis, if the child goes on to develop hematuria, well, luckily, even the Sydenham chorea that you found, that we'll talk about that later, but anytime that you have a group A streptococci, for the most part, take care of the bacteria, antibiotic, and many a time you're going to be looking for treatment of that hypertension. And the reason that I just mentioned the Sydenham chorea is those that occur with a non-nephrogenic, with pharyngitis causing rheumatic fever, it can be reversed. And that's amazing. Many times, especially with children, when things go on to become irreversible, that is extremely sad. But group A streptococci tends to be one in which you can treat antibiotically, and the manifestations that might be taking place later on, either in the heart or in the kidney, may be reversed quite dramatically. Usually resolves, and chronic renal failure, fortunately, in a child, uncommon. 95% of your children who have PSGN will recover. What kind of deposit is this? You have memorized subepithelial deposit. Supportive. Look for that hypertension. That's huge. Highlight that first. As far as the organism is concerned, you have penicillins that are coming in if and when your patient's positive for streptococci. I say if because here once again you could have non-infectious type of glomerulonephritis, which I shall go into in the pit. And they are dialysis. I mean to say that if there's kidney damage and during that time, if you need to clear out the organism and if there's emergency hemodialysis that's required, yes, you don't hesitate. But antibiotics are a must, and you must treat that hypertension when it's present. Now, with the streptozyme test, important ones that you want to keep in mind here. Typically rise, what you're seeing here in green. ASO, anti-streptolysin O. Anti-hyaluronidase. Anti-nicotinamide or adenine dinucleotidase. All part of typically rising in post-streptococcal, post-pharyngeal is what we're looking for. Anti-DNase B antibody. Once again, post-pharyngeal cause. Are we clear? Of what? Resulting in PSGN. Next, post-skin causes. And by skin, it's still the same organism. What is it? Group A streptococci pyogenes. Maybe perhaps you're thinking scarlet fever, impetigo. The two that are typically risen under skin would be anti-streptokinase and anti-DNase B antibody. And these you'll have to memorize. Keep these in mind. Many a time, the PSGN is going to rise from the strain that is given rise by the skin streptococcal. It's imperative that you know these streptozyme tests for all clinical purposes. Labs. What are we looking for? Well, we have nephritic. Talked about hypertension and its importance for management. Next, you do have your hematuria. And under hematuria, RBC casts? Yes. Could you find RBCs? Sure. Most likely, what kind of RBCs? Dysmorphic. Because you've activated your complement system, you can expect there to be deposition of your complement, and thus, in your serum, you have hypocomplementemia, specifically C3. Next, as far as your streptozyme tests are concerned, well, we just went through both of the strains, pharyngeal and skin. Anti-streptolysin O, anti-DNase B, anti-cationic proteinase. Clinical features, prognosis, children, recovery, 95% and greater. Adults, not so much. Some may progress to RPGN. Keep that in mind. When we get into RPGN, I'll show you the difference. It's the fact that your kidney, as the name implies, rapidly, and by rapidly, within 3 months, 12 weeks, that kidney dies. Now, does it occur commonly? Luckily not, but keep that in mind because if not properly treated, there's every possibility going to RPGN.